very pleased today to welcome Heli Yola and Sasha Johnston. They're both psychogeriatric resource consultants from the Psychogeriatric Resource Consultation Program of Toronto. A brief introduction of them. Heli is a social worker and is the program lead for the Psychogeriatric Resource Consultation Program of Toronto. Sasha is a registered practical nurse, and both have a wealth of experience and knowledge in dementia and mental health, and have been instrumental in supporting long-term care homes with capacity building and implementing behavior management programs and processes. Heli and Sasha also support the Behavior Supports Ontario initiative and facilitate various core curricula such as PIECES, GPA, and the PRCP Toronto Behavior Support Resource Team Lead Training. Before we begin, I'd like to let you know how to engage with our presenters today. Please type any questions or comments you have in the chat box at any time. We will start our conversation and question period around the end of the presentation. I will answer the most commonly asked question. Can we have a copy of the slides and recording for this webinar? The answer is yes, you can. We will send the slides to you and we will be posting the webinar link on our website and also on our YouTube channel. And with that, I'd like to invite Heli and Sasha to take the stage.
Good morning, everybody. Thank you so much for attending. This is, I guess, session 5 of our COVID-19 long-term care orientation for redeployed healthcare workers. This series has been, this is our 5th one. So if you have joined us before, thank you so much. Today, we're going to be focusing on supporting residents with responsive behaviors during feeding and medication and treatment administration. We first always want to start by thanking you for supporting the teams in long-term care and caring for the residents during this pandemic. We really appreciate that you're, the time that you're putting in and the time that you're taking to join these webinars to maybe learn a little bit more about how you can support people with dementia and who exhibit responsive behavior. So thank you. Just a couple points for housekeeping for today's session. As Mario mentioned, the slide deck will be shared with you shortly following the training, so you will have access to these slides. The session will be recorded and it will be posted on the RGP Toronto YouTube channel. So you can also check out this session and any of the pre-recorded sessions in this series on that YouTube channel. Any questions that you do have, please type them into the chat box. You will have an opportunity for questions and answers at the end of the webinar. And we want to let you know that although we recognize that there are some specific case examples that may require resolution, we'll not be able to address specific case scenarios due to the time that we have. But we do encourage that you connect with any of the behavior supports in the facility, as well as any of the external supports that you have for long-term care. So our goals for today, we want to understand the resident's experience during feeding and medication or treatment administration. So we're going to talk a bit about that experience. We're also going to look at some strategies that we can consider when we're faced with some of these experiences. And then also looking at how we can manage escalation if that's something that you're coming to face when you're providing feeding or you're giving a medication or treatment to somebody with a dementia diagnosis. With that, I'm going to pass it over to Heli to start the session.
Thanks, Sasha. So if you've been to previous webinars, you know we like to find out about our audience at each session. We're going to launch 4 poll questions to get to know a little bit more about you. Carrie, if you could launch the first question, please. So we're just asking folks, have you attended previous webinars in this series? Okay, great. So we've got 75% of folks have and 25% haven't. So welcome to you and welcome back to those who have been here with us before. If you could launch the second question, please. So what is your role? So we're always curious to know who's out in the audience with us. So we've got a number of different disciplines and backgrounds here. And we do ask if you aren't listed here, if you wouldn't mind putting in the chat box what your role is if it's not on our list here. Okay, so we've got about 25 or 27% today of the audience are nurses. 13% we've got OTs, occupational therapists. We've got about 27% PRCs, 7% administrative, and 27% other. Okay, so thank you very much. So we'll launch our third question. So have you worked or supported older adults with dementia before? Okay, 100% of the group has worked with older adults with dementia before, so that's fantastic to hear. And we have just one more question just to find out a little bit more about who's with us today. And that's, how many years of experience do you have working in the field? So I'll give people a moment to input that. Okay, so thank you. So we've got about 12% have 0 to 5 years, 24% at 6 to 10 years, 12% with 11 to 15, and 6% with 16 to 20 years. And we've got almost half of you, 47% at 21 plus. So thank you very much, everybody, for giving us that information. It just helps us to understand a little bit about who's attending the webinars, as well as we're talking about some of the content today. If you might have had experiences working with older adults living with dementia before. So as we move into our topic today, we want to recognize that oftentimes in long-term care, the routines of daily living can become very task-focused. Daily tasks like handing out medications, providing treatment, or providing a meal can start to feel mundane for us. But for our residents, it may be one of the few interactions they have with others during the course of their day. We could consider tasks as an opportunity for a moment to connect. So I'd like you to consider this as I show you some long-term care images, and I'd like you to reflect on how you feel as you see each image. So how do you imagine this woman is coping with eating in isolation in her room? So here she is again, but she seems to be having a much different experience in the same situation. Recognizing little steps we can take to make an experience better. Turning a light on, opening the curtain, seating the individual near a window, engaging the resident in conversation, dressing the person for their meal. All of these things can potentially make an impact. Okay, so with the next image, I'd like you to imagine that you're feeling unwell and a nurse comes to you and wants to provide you with some form of treatment or medication, and your response in the moment is, no, not now. And he reacts like this. How comfortable do you think you might be feeling later on if he was to reapproach you to offer medication or treatments? Now let's say the same request is made of you and you give the same reaction, no, not now. But this is how he reacts. Do you think you might respond differently now? Consider, even with a mask on, we'd be able to see the friendliness in his eyes. Always remembering that nonverbal communication does speak volumes. Okay, so this is my last set of pictures. Does this look familiar? Can you identify what's on those plates? How about now? These are all pureed foods. We recognize that you are likely not going to be the one preparing meals, but there are small changes we can make to make the meal more appealing. For example, not dousing the meal in gravy, not mixing foods on one spoon, If you don't have the opportunity to make it more appealing, explain to the person what it is that they're eating and making sure it is the appropriate consistency and texture of food for their swallowing abilities. So as we move on, we want to encourage everyone to be looking for those moments of opportunity to connect as we consider understanding the meanings of behaviors. We've looked at this in previous webinars, but it really lays the foundation to help us find those meaningful ways to support care. As the first point says, in dementia care, behaviors are viewed as responses to unmet needs. Part of the challenge is there are so many possible unmet needs that may contribute to a response as a person's behavior. We will be exploring a few of those today. Also, keeping in mind, we want to avoid labeling behaviors. Words like aggression, hoarding, inappropriate are terms that tend to judge the behavior rather than try to uncover the reason for the behavior. As the last point says, this work can be time-consuming and resource-intensive, however, can be quite rewarding. When we figure out steps we can take to improve someone's quality of life, again, we encourage you to connect with the teams in the homes to learn about the person and their individualized care plans. When it comes to behaviors that are a response to negative stimuli, physical causes are a big one. PIECES is a widely utilized framework that helps teams uncover those meanings behind behaviors. We will be talking more about the impact of our approach next, but we have to acknowledge that with even the most gentle, compassionate, friendly approach, if the person is pain, the first thing they will likely be reacting to is the pain and not your friendly demeanor. As an example, I'm generally a mild-mannered individual, but I also live with chronic back pain, and after one particularly bad flare-up, I needed to go to the emerge department by ambulance. And I still have a very vivid memory of yelling at the paramedics while they were transporting me. This is something I would never do in my usual existence. But the pain was in control, not me. So if you have a resident who cannot express their pain and we're not adequately managing that pain, we may find situations where the pain is in control and not really anyone or anything else. Delirium, similarly, has the potential to ambush a person. If you have ever seen someone in a delirium, again, the condition will cause the person to not behave the way they would under normal circumstances. And people living with dementia are at risk of developing a delirium. So ruling out these types of physical changes are a key first step to identifying and treating, as this increases the team's ability to improve the person's functioning and coping, not to mention being potentially life-saving. I'll briefly touch on the other Ds as physical causes. With the category of drugs, one of the key messages we want to consider is polypharmacy contributing to confusion or side effects that may be exacerbating the situation? With disability, can they see us and hear us to the best of their ability? Again, with the aim of minimizing misunderstandings. Lastly, of the 5 Ds listed is disease, which serves to remind us that symptoms of various disease processes can contribute to a person's ability to cope with situations. For example, a person living with COPD, chronic obstructive pulmonary disease, may become afraid during a shower because the steamy environment may worsen their symptom of shortness of breath. And if they can't tell us this, for example, if they are experiencing aphasia, we may see a behavioral response indicating something is not working for the person. The 5 Ds of physical causes really does a good job of helping us and the team to attend to the physical well-being of a person to support them. And again, for those who have attended previous webinars, this will look familiar. It's a simple way to think about how our behaviors, and by our, I mean all of us, so how our behaviors happen during social interactions. In the upper right-hand corner, we see cognitive. And part of this is our ability to use sensory information to understand the environment that we're in. We can understand and use cognitive functions to help us interpret, understand, and perceive the situation where we find ourselves in. And this works hand in hand with the upper left-hand corner, the affective component. An affect lets us know when things are going well. We feel happy, we feel joy, we feel good. Can also let us know when things are not going well. We might feel anxious, angry, or afraid. So our cognition, along with our affect, influences our behaviors. For people living with thinking changes associated with dementia, it's helpful to recognize that our approach may be perceived in a way that results in a misunderstanding that may lead to negative emotions, which can result in that responsive behavior. So we encourage you to think about those moments again of opportunity to connect as you begin these social interactions. And this is what the next few slides will help us to think about, how a change in our approach may result in a different outcome. So we know that cognitive changes can lead to misinterpretations and misunderstandings. And we'll start with environmental misperceptions. An example of a behavior or situation we might see is we may see someone not finish their meal, but state they're still hungry. With altered perception, people don't have the same ability to see colors on the lighter end of the spectrum. So for example, mashed potatoes may disappear when they're placed on a white plate. Common response to this may be, why didn't you finish your meal? A strategy to consider that may be more helpful would be to cue the person to the potatoes by saying something like, those potatoes look tasty. Would you like to finish them? And if you notice there are different colored plates available in the home, consider using those. And lastly, consider using appropriate condiments that provide color contrast between the food and the plate. Another behavior situation you may encounter with environmental misperception is when people experience changes to depth perception and their peripheral vision and may think their table mate's plate is theirs. So a common response is, that isn't your food, don't do that. Some strategies to consider would be include and make sure that the plate is within their field of vision, and provide cueing to the location of the plate. When we think about loss of peripheral vision, I'd like you to just take a moment. Put your hands like binoculars around your eyes and have a look at what you see. Imagine if there was a plate on the table in front of you. Would you be able to see that plate? Or are you more likely to see what's happening more directly in front of you? So if you think about that as a way of helping us to sort of imagine how people with dementia might be misinterpreting what is theirs in the environment. And so thinking about how we can try and place things in their range of their field of vision. Also thinking about having cutlery in view and placing things on their stronger side. With loss of initiation, it's important to recognize the person may appear that they don't want to do the task, and they may get labeled as being difficult or refusing, but their behavior may be their way of telling you they don't know how to do the task, and in fact, they need some help. Recognizing what the person can do for themselves and finding ways to encourage them to do it are so important. So an example of a behavior or situation you might see is the resident is sitting in their room after the meal is served, but they're not eating the meal. Some typical responses we may see are that staff just assume the resident's not hungry and they take away the plate, or they assume the resident requires total help with eating and begin to feed the meal to them. So some strategies to consider are to provide visual and verbal cueing before touching the person with hand over hand cueing. If there's one message you take from today, I think this would be one of the important ones, that we should never use touch as one of the first ways to communicate with a person living with cognitive changes. This can be very startling. The order we want to try to use to gain their attention is visual first, verbal second, and touch is third. Another good practice is to allow the resident to do as much as possible for themselves. If we step in and do the task for them, you may see this can escalate a person's reaction. The other issue is over time, it can cause a faster decline in a person's functional abilities. I'll now turn it back over to Sasha.
Thank you, Helly. Sorry about that. I was having a little bit of trouble unmuting myself. So we're actually going to move forward with some of these losses. And the next one we're going to talk about is the loss of insight. So this one is, I'm just going to make sure this is on here. There we go. So the loss of insight, if we remember from some of our last webinars, is that inability to kind of understand that there is some sort of illness even present in the person. So the person with the dementia might not be able to understand that they need help in certain areas of their activities of daily living. So when we think about medication administration, I know that there was a lot of nurses who are in the room, so I'm sure that this is something you've probably come into some situations that you were facing. When we look at medication administration with the loss of insight, they're going to tell you that they don't really need to take medication because there is nothing wrong with them. So they often will say, no, I don't want that. They'll refuse to take it saying, I don't need it, there's nothing wrong with me, or they might even just spit it out on the floor and just say, I don't need that. And oftentimes we'll try to use things to I guess, have them understand that they need the medication. You know, we have their best interest in mind. You know, your doctor says you need this medication. If you don't take it, you're going to get sick. And even sometimes we might use authoritative language, like if you don't take it, I'm going to tell your daughter. This can actually cause an escalation in the behavior because in their mind, they don't need it. There's nothing wrong with them. So they don't need that medication. So one thing we might want to consider is crushing medications into a small amount of a sweet food. And what I mean by that is that we have to understand that in order to crush medication, we have to have consent from a POA, and we also need to have a doctor's order in place. We also want to be cautious about the types of medications that we're crushing because some medications are extended release medications and therefore should not be crushed. So it's always good to speak with the doctor and the pharmacist as well. We also want to make sure that we are putting it into a small amount of sweet food. And the reason why, and I say about a teaspoon, is because if you've ever tasted medications, I think we all may have tasted a Tylenol every once in a while, they're very bitter. And if we provide it in too much of a food, the chances of them taking the whole amount of food is very slim. So we want to make sure that we get it all into the one spoonful. That way they're only taking one bite. And I usually say something like a jam, which most people use, or an applesauce would be something that we could provide it with. Another strategy is we could try to give them an explanation that they will buy into. And what I mean by that is that you want to give them something where they have express the need for maybe needing something. So for example, if they say that they have been experiencing some back pain, you might want to say, well, Mr. X, you mentioned that you're feeling pain in your back. So this pill could help you with that pain. They might be more likely, if it's something that they've expressed that they need, they might be more likely to actually comply with that medication. Another thing that we can kind of use and often use in dementia behavior management is kind of distracting them. Engage them in a distracting topic, talk to them about their day, talk to them about how they're feeling, etc., while providing that medication, and they might just clue into that's their daily routine and they might be distracted by the topic. So with loss of recognition, this is another one that we've talked a bit about. So this is basically when someone is unable to recognize people, places, or certain things. And again, this can happen with medication administration. So once they've put the pills into their mouth, they don't recognize what it is anymore or what to do with it. So you might see that they spit it out on the floor because it's hard and they're not really quite sure what it is. And they'll say, "What is that?" Because they're not quite sure of what it is, or they'll start chewing it because they're not really recognizing what it is and they don't remember the process of taking pills. So often we'll be like, "Oh no, that's your medication. Don't chew. Oh, stop," because we know that that can be quite bitter. So a strategy to consider for medication administration is to show them and explain each pill. So you say, "This pill will help you with your pain. This one is for your diabetes. It's going to help with your blood sugar." You're also going to want to show them how to swallow with water. If their loss of recognition has gone past the point of explanation, this might be another point in time where we want to think about changing the administration method. So again, looking at crushing the pills if possible, or looking at even a different formulation of the medication. When we're thinking about feeding, I'm sure a lot of you have seen this as well, is that they have their drink and they have their food, and then they start pouring their drink into their food and they're mixing it all around. And we're like, "Oh no, why are you mixing that? That's not going to taste very good." And so we want to try to look at how can we set them up for success. One of the things that we can do is that we can provide them minimal items at a time. So maybe provide them with their mashed potatoes first or their meat item first, and then in between offering and switching out items. So if they think that they would like a drink, we switch out the meat and we give them a drink. So that way there's only one thing to concentrate on at a time. So we also want to limit the amount of items that are on the table. So sometimes they'll have a salt and pepper shaker, sometimes they'll have a condiment or whatnot. So removing those items so that way they're not mixing all of these different things because they feel that they have to. The next one we're going to look at is loss of language. So when we think about medication administration, and the person is unable to express to you verbally how they're feeling or what they want, or if they're in pain, or maybe they've been having some side effects from that medication and they know these things, but they're unable to verbally tell you, they will show you with actions. So again, like Helly had mentioned with the ABCs of cognition and of our behavior, if they are unable to express it to you in one way, that might get frustrating. So they might just show you with an action. So one of the things you might see is they'll take the pill and they'll throw it on the floor. And we'll be like, "Well, why did you do that? That's your medication." And they might actually be trying to explain something to you. So one of my experiences that I've had is that, I've witnessed a resident throwing Tylenol on the floor, and then they were gesturing towards their buttocks and rear area. And what we kind of realized was that they were trying to express to us that they were experiencing constipation. And as for those of you who don't know, Tylenol actually can be very constipating. So it was one of those things where they just kind of showed us and they had to gesture to really get that point across because they weren't able to verbally tell us. So one of the things that we can do is provide them time to process the information. So when we're providing these pills, we want to explain what they are, like we mentioned in the last point, but also give them time to process. So it takes a little bit longer for people with brain changes and dementia to receive that information. And then you want to try to look for some sort of visual cues that they have received the information and are understanding it. We also want to make sure that we're taking a look at looking at bowel protocol and some of these things too, because if they can't express that, then we want to make sure that we are putting something in place that will assist with that. With feeding, when you have loss of language, you might see things like they're not verbally responding and they're pushing away the spoon. And oftentimes not being malicious, but as care providers, we really want people to be, well fed, and we want to make sure that they are nourished, and we want them to not be dehydrated. So we'll be like, "No, you open up, you have to eat." We really want to, make sure that they have that that nutrition. So sometimes we have to understand that maybe they're not hungry anymore, or maybe they don't want this food, or maybe they don't really particularly like that food. So again, we want to provide them with visual information. And as Helly mentioned, we always want to do visual first and then follow with some verbal cues and explain what the food is. And if we're still seeing that, we're like, here's your peas, and they're still pushing away the spoon, then we might want to say, okay, you know what, maybe they don't want this food, or maybe they're not hungry anymore. And we can move on to a new item on their plate to see if it's maybe they'd like something different, or maybe it's just that they have had enough to eat. So moving on, we do have a couple of other strategies. I know that with feeding, medications, and treatment administration, there are so many different scenarios that we could bring up and talk about, and it could go on forever. But for the sake of time, here are a couple of other things that we can think about when we're providing these different care activities. So for feeding, we always want to make sure that we're checking their care plan for food and drink preferences. So this can be something as simple as checking how do they like their tea and coffee? Do they like tea or coffee? And making sure that we provide their preference. We also want to look at, do they eat dairy? Are they vegetarian? Are there certain diet restrictions? Are they diabetic? Do we have to consider salt? So there are a lot of things that are associated with food that we really have to consider when we're providing the meal to our residents. Another thing that we can consider is finger foods. We often have people who have short attention spans when they are diagnosed with a dementia. So we want to think about, for those people who may have an issue with sitting down and staying seated throughout their meal, you might notice people get up, they walk around. We might want to consider some finger foods for them. So something like sandwich slices, or even carrot sticks, depending obviously on their swallowing abilities, but different things that they can use so they can still eat while they're kind of walking around. With the time of COVID, I understand that wandering is much more restricted, but they still can kind of go about their room and have these finger foods. Another huge thing is to match your assistance to their abilities. We want to make sure that we're not outpacing them. So we want to give them the opportunity to be involved in their care as much as possible. It's, again, with that loss of initiation where sometimes they are unable to start their meal themselves. Sometimes by using those visual, then verbal, and then hand over hand techniques, they'll be able to start that task and complete it. It's just that initiation piece. So we want to make sure that we're not taking over and we're providing them time and the opportunity to take part as much as possible. Another thing we want to make sure is that they have all working aids in place. So we want them to have their hearing aids, their glasses. We want to make sure that they have their dentures in. Everything is set up for them to actually have a successful meal. Lastly, for those that we do have to care for and we do have to provide them with their meals, we always want to ensure that they're in an upright position, and we want to make sure that they have the position to have coughing clearance. So we want to ensure that they're sitting up in an upright position, so that way they're able to swallow and decrease that risk of aspiration pneumonia. With medication administration, there are many things that we can do to kind of provide a little bit more assistance in terms of helping them understand why they're taking their medication, how we can have that increased compliance, and also to increase the opportunity for them to get the full dose. So we want to consider the consistency and the preparation. So if they have swallowing difficulties, suspiciousness, or they have that loss of insight where they don't feel they need the medication, we can choose different consistencies to facilitate easier administration. So this can include changing Tylenol from an oral pill. We can give it in a liquid format, or we can look at sublingual medication, and even further on through the progression, we can start looking at things like subcutaneous administration and other things that are easier for the person. Another very important thing to remember is that polypharmacy is so prevalent in our geriatric population. I have seen so many medication administration records that have 14 plus medications. Some of them are priority medications. So things like looking at analgesics, so things that help with pain. We want to look at diabetes medications. We want to look at antihypertensives. And we also even want to look at those, you know, antipsychotics or antidepressants, and those are important as well in their care. So what we can do if we know that somebody is a little bit more resistant to taking their medication is we can prioritize those important ones, have them take that first, and then things like calcium, vitamin D, we can try to provide those at a different time because 14 pills is a lot to be taking at once. So prioritizing the most important medications and then maybe reapproaching later to provide the rest. Lastly, we want to look at providing medication appropriately. This includes we never want to place medication on top of their meals. I did hear a story that somebody was crushing a medication and then just kind of pouring it on top of their lunch or their breakfast. We want to understand that if they taste that and it's not tasty to them and they don't enjoy it, that we might risk the chance of them not eating their meals now. The other thing I would like to say is that we never really want to put it in their favorite food. A lot of times people know that their residents love, love, love ice cream. But once we start administering medications or crush medications into that favorite food, we kind of diminish that experience for them. So we want to make sure that we're using something sweet like jam or applesauce because it's not necessarily a favorite, but it's something that can kind of cover up the bitterness of the medication. We want to emphasize that meals are to be enjoyed and used for celebration. I think that all of us enjoy our meals with our families. It's a time to socialize. So we really want to ensure that we're providing that meal time to be that and not necessarily about administering medication. Finally, for our treatments, we want to think about considering only necessary monitoring. And what I mean by that is that looking at blood pressure checks and glucose monitoring. And of course, it's important to ensure that we have the appropriate monitoring in place, and we want to make sure that we're looking at blood sugars. But if we have somebody who's been taking a metformin, say, for the past 10 years and their blood sugars have been quite stable, maybe we don't need to be checking their blood sugar 3 times a day or at every meal, or maybe we can look at maybe just checking it at important times, like in the morning. Also for blood pressure checks, maybe we can do that once a day or instead of once per shift, or just looking at when do we really need to be doing that, because that can be quite uncomfortable and it can provoke some behaviors. Ensure that before treatment, we always want to provide the pain medication prior to. So for example, if you have to provide wound care or another uncomfortable intervention, we want to ensure that pain management is provided 30 to 45 minutes prior to the intervention. And that way we are decreasing the chance of them, again, having that pain kind of take over and act for them when we are doing that treatment, which can provoke some of those behaviors. One of the other things is utilizing PRNs appropriately. So the PRN medication is there basically to test the need for an increase in dosage or an addition of a medication to the resident's care plan. For example, if the scheduled pain regime is not sufficient in managing their pain, we use the PRNs and we document so that the doctor can see that there is a need for increased scheduled medication. This helps us to really fix that physical piece that Helly was talking a lot about. Providing that pain medication will decrease that chance of the person reacting and behaving due to the pain that they're experiencing. So when we're thinking about managing escalation, this is just a very kind of brief introduction to kind of things that we can do in these particular situations. When we see that a person is getting upset, we want to consider stopping what we're doing and stepping away. This is a good thing for any care that we are providing. If we're noticing that the person is getting escalated, even just stepping back for a couple seconds, you'll see that they start to de-escalate. They're going to breathe a little bit better, and you might even not be as tense. So giving just a couple seconds to kind of step away. If it's safe to do so, you may want to leave and leave the person and go do another care task for someone else and reapproach later. So someone we're feeding entirely, we may not want to leave, obviously, because it's not safe, and also they haven't finished their meal. So we may just want to take that step back for a second, but we don't want to leave the person alone. Lastly, we want to avoid correcting the mistakes or telling them what they need to do. So we want to avoid statements like, you have to take this medication, or you have to eat, it's lunchtime, because these are people who have had their whole lives, they have their whole experiences, they're parents, right? So they don't need authoritative kind of, you need to do this, you need to do that. That will only further escalate them. So we really want to be partners in their care tasks versus being people that have to kind of tell them what they need to do when they need to do it. Because we want to understand that behavior is a personal expression to an uncomfortable and perceived potential threatening situation, which is really kind of the summary of our foundational principle of behavior support. We really want to know that if we provide them a more relaxed and a more supportive environment, then they are going to respond much better to that. So in closing of our webinar, I would really love for you to just take a moment to think about this quote and to read it and really just let that settle in. And hopefully you will think about these different times of interaction as moments of opportunity to support our residents in long-term care during not only feeding and medication and treatment, but during all of your interactions that you do have with them. Here are some resources. And again, these slides will be sent to you, so you will have access to these. And there's just a couple different things in there. So again, the RGP Toronto. So we'll also have these webinars that you can go to also on the YouTube channel. And you can check these out for a lot more great information about some of the COVID-19 care strategies and just some information to help you throughout your redeployment or during your regular work. So thank you so much for joining session 5. It was really great to kind of have this opportunity to speak with you guys, and I'm looking forward to some of your questions. But if you could please let us know if this was helpful, and are there any other topics that you would like to see or that you feel that you would need some support in?
So thank you, Helly and Sasha, for an excellent talk, and also for sharing your experiences and your practice with the topic. At this point, we're going to be opening up the questions. So please, if you have any questions, please type it into the chat box. So while you're typing your questions in, there is a question that has been asked from long-term care homes during this pandemic. Many would say that the social aspect of dining has been significantly reduced during the pandemic. What are some suggestions that you have to really help to support the residents' social needs and continue to make this a part of their dining experience?
I think just sort of reflecting on those images that we looked at the beginning of the webinar, there was the woman that was eating at the table and we were imagining her dining on her own in the room. Looking at those kinds of moments of opportunity to connect, right? And so when you're bringing a meal or getting the meal, that's a time when you can have a conversation with her and engage her in some discussion. And I also think that that's a good opportunity to find out a little bit more about the person. So getting some information from the care team about her likes and interests, so that you can engage her in conversation that's pleasant and meaningful, but also serves as a distraction to her. So that's one way to try and think about those opportunities. And I know, Sasha, you've talked a little bit about hearing about people having Zoom chats during meals.
Yeah, so there was some things that some of the care staff that I was speaking to would set up during meals, and that was some people are home from work, as I'm sure all of us know. So some family members would be available to have their meals with their loved one in long-term care over Zoom. Um, Also, I heard about some people having their meals in their doorways of their rooms, and they'd be able to see some of their co-residents in their doorway. So they were still distanced, but they were able to kind of have that a little bit of socialization during, obviously a time where that's been quite decreased. But and also, yeah, looking at rotating residents, I heard, and I know, like having maybe I think it was per unit, they would have maybe 2 residents in the dining room and they would rotate so that there was still less people in the dining room, but also give people an opportunity to have a meal with someone, obviously following all those protocols.
Thank you. It's it is a very challenging time to really think about the social aspect. But thank you for those suggestions to that question. It appears that we don't have any other questions. I mean, we'll give you a moment maybe to have participants type in any questions. Well, the webinar will be posted on the YouTube channel, and the link will be posted as well on the RGP website. The material will be shared with you on email. So please, if you want to review the content again, you're always more than welcome to. Also, just please don't hesitate to connect with the behavioral supports that support the long-term care homes for any other ideas or even suggestions when it comes to particular residents that you may be working with. So with that, I'd like to thank both Helly and Sasha for, again, a very informative session. And we hope that you all stay safe and have a wonderful rest of the day. Thank you.
Thank you so much.